Good. Well, welcome everyone. We will we'll get started. We have a fair bit of material that we can go through, though we also recognize that we want it to be as interactive as possible, so we'll encourage any interruptions or comments or concerns that people might have as we go along. So we'll introduce ourselves. Why don't you go first?
Sure. Jacqueline, I'm a palliative care consultant. I work in the acute care South Park campus mostly. It's in Calgary and also in the rural areas as well. I'm also the program director for the palliative care residency program.
Yeah, I'm Ron Spice. I'm also a palliative care consultant. And I guess the only other thing that I might bring to this is I am also I have an administrative role with Calgary Health Services as the zone clinical director for rural health for Calgary Zone. From that side, of course, I've seen this from an administrative standpoint about policy development and rollout and managing some of the sort of upcoming and then completed medical assistance and dying processes from an administrative standpoint as well. So I'm going to manage the slides and let Jacqueline get started.
So in terms of financial and commercial disclosures, we have none. And to be completely transparent, we're actually not involved with the MAID coordination team as well. So this is an interesting course because Ron asked me a while ago to help him with this course, and it's really about teaching MAID. But I think that comes with the assumption that we are already experts, or we have some knowledge that we can impart to our learners. And I'm not sure with MAID that's the case because it's new for all of us. And even as in palliative care where we encounter these requests more often, I would say not everyone has a lot of first-hand encounters. So just to get a lay of the land where we're at, because this will drive some of our presentation as well, is really where are you guys in terms of comfort? So how much do you know about the legislation, policies, processes around getting a request? How do you respond? And would you say you're very comfortable? Show of hands. Anyone? So a few. Okay. How many would say, somewhat comfortable? Okay. And then not at all. Okay. So we have a wide breadth in here. So I think we're going to start off and just to go through everything, give you some background. We'll talk about how to prepare your residents, but really we'll throw in some alternatives to MAID as well and talk about how we view MAID. So this is supposed to be interactive, so please interrupt me while we go. So maybe I'll start off with a few cases. And it's interesting, when we were first told that this legislation is falling through, we met as a palliative care group, we were told we're probably going to have a few per year that we're going to deal with. Well, just this week, just to highlight the few, from Wednesday to Friday, I had 5 requests. And I think these patients are, the cases that we chose are pretty reflective of the cases that we get. So from non-malignancy, so I had 2 that had cancer, 1 who was probably more imminent, 1 who had months to go. I had a COPD-er, a CHF-er, and a new diagnosis of HIV/AIDS, all requesting MAID. So really a breadth of patients. So hopefully our cases will reflect that as well. So we'll talk, I'm just going to introduce the cases and we'll talk more about them at the end. So this is guy, obviously in acute care, 42-year-old, aggressive metastatic melanoma, widespread, pneumonia. He's kind of in and out of it. And the wife is saying, we've had this talk a long time ago. You know, he would never want to be like this. Isn't there something about assisted dying? What can you do? How do you respond? So what do you have to consider? What are your options? Can you provide MAID in this scenario? What are your obligations and what do you teach your residents? So next case. So a different gentleman. So these patients you're seeing in your office. I know you see lots of these guys. Older gentleman really has a lot of comorbidities, but the big thing with him is IPF, restrictive lung disease. He's been in the clinic lots. and his home oxygen needs are going up. 2 liters, now 6 liters. He's had a few hospitalizations, and he just doesn't like the way his life's going. He can't go for coffee with his friends anymore. And I just had a patient like this who told me, if I can't go with coffee for my friends, I'm not wanting to live. So this is this patient. And he's asking you, he wants to end it. How do you respond to that? So, same questions. Okay, next case. Anyone manage an ALS patient before? Okay, so you know how tough this is, right? Anyone do home visits here? Okay, so a few. So these are the patients that are tough. Like, even as a Palliative care consultant group, these patients are so hard to manage. So this patient's at home, and you're doing a home visit, and really lots of decline in terms of motor and function, but bulbar sparing. So she's able to talk to you, she's eating still, but she's starting to have some respiratory failure, BiPAP dependent, mostly nocturnal. And have you guys ever seen the sip fence? So every time they talk, they have to sip a little first, and to eat, needing that mouthpiece vent. Lots of secretions, lots of symptoms. She says, I'm still enjoying my time with my family, but just an overall sense of I'm being a burden, I'm suffering. They've had a family discussion. I have a date picked out. Help me carry this through. How do you respond? So same questions. Any of these familiar to anyone? Yeah, so before we talk about how to respond, maybe just to take a step back. I think everyone recognizes this artist. Van Gogh committed suicide at the age of 36. Typical in the sense that he is male, isolated socially, and just had a lot of mental illness and angst as well throughout his life. But the more typical person that commits suicide is actually older. Anyone hazard a guess how many suicides we have a year in Canada? Thousands, hundreds. So the last statistic I got from a psychiatrist was 4,000 a year. So assisted death came into legislation in around summer of 2016. How many deaths have we had through this route? So over 2,000.
In Alberta.
Oh, in Alberta, over 100. Across the country, over 2,000. So just to give you some context, right? So the rationale for assisted death originally was, if you look at the right, support the right to die, at least you're honest, I support the right to needlessly suffer, right? So people, death with dignity, those groups were touting, people are suffering, there's no need for this. The public has spoken, we need to give people options. The other rationale was, my life, my death, my choice. I'm going to go the way I want to go. And so 70% of Canadians that were surveyed wanted this. So when we're encountering MAID requests, what do you think is more at play here? Is it the suffering? It's both, for sure. Is it control? What do you think is most of the patients are coming with? What is their rationale?
Choice.
It's choice. It's about control. Most of the time it's about control. And the ones that I've personally been involved with, almost inevitably it's about control. There is definitely suffering, but it's a lot of existential, a lot of the symptoms we can control when palliative care is involved, but it is about control. So just to have that in context, right? Next slide. So the bill was C-14, and that was, I think, June 2016, and it was really decriminalization of assisted dying, right? And there's two ways for this to happen. So you can administer it. It has to be a nurse practitioner or a medical physician, or a prescription, so physician-assisted suicide, right? So get a prescription, has to be, again, a nurse practitioner or medical doctor, and a pharmacist gives that to you. As far as I know, there has been no physician-assisted suicide in Alberta to date. I think it's happening in the north, where there aren't many teams that can provide the administration. So correct me if I'm wrong, but that's what I heard last. You know any different, Ron?
No.
Okay. So criteria, you have to be Canadian. So can't be someone from our friendly south that wants to come up because they only have assisted suicide in the 6 states. They can't want to come for that kind of death. 18-year-old plus, there was a lot of debate about mature minors. That is not legislated to date. Capable of making decisions. So this is a very contentious one. And I wonder if the legislation is going to change because of this one point. So right now you cannot advance plans. So say you have a diagnosis of ALS or dementia, and you know you're going down that route where you're going to lose capacity, you cannot plan for your death. You have to be competent at the time. So I think what this has resulted in is some angst around that period where people are very afraid to lose their cognition and their capacity, so they are rejecting a lot of the medications and some of the therapies that could be therapeutic because they want to hold on to their competency. The second thing that's doing, I think, is driving decisions earlier than may be needed. So something to think about. Again, voluntary, you have to have consent. And the last one I'm going to talk about a little bit more because, again, really vague. What does grievous and irremediable mean? So they have to meet these criteria: serious, incurable, advanced state of reversible. Again, C is a little bit vague to me. Causes enduring physical or psychological suffering. So in the patient's view, not yours. The natural death has become reasonably foreseeable. So I'm going to talk about a case that I saw on Wednesday, which I'm having some issues with. And this is a 36-year-old gentleman who is gay, Indigenous, so already that comes loaded. And he's alcoholic, he was assaulted, had a C2 spine fracture, ended up almost a quad, but ended up being a bit more mobile, had fusions in his back, just a lifelong of suffering. So it's been years and years of chronic pain, suffering, disability, unable to work. And he has a new diagnosis of HIV/AIDS with Kaposi's, potentially treatable Kaposi's, and HIV could have been made chronic, right? So the AIDS piece, if he took his ARVs. So in all of this, he said, I'm done. And I don't want anything, leave me alone, I want MAID. And the MAID team was seeing him. But I wondered about some of the questions, because is he overwhelmed? Is he just in a vulnerable state? The physical and psychological suffering, he's never been seen by our team until now. Would it have made a difference if he saw us for a little while first? A lot of questions around that. Any thoughts about that patient even? Yeah, I don't know. I just really struggled with that one. Some of them are just more clear-cut, and I wasn't sure. Yeah.
Is there any precedent for when you say natural death, reasonably foreseeable for natural death to include suicide? And that he'd obviously be at hugely high risk for suicide. Does that count?
So he was seen by psych actually to make sure he's not depressed, suicidal, incompetent. So that doesn't really count.
Well, I'm just thinking when you say he's done, we include the Indigenous aspect, the age, everything else. Whether or not he's depressed, the risk of suicide is still high.
It's still high.
I'm wondering if that'd be a case where the prescribed approach of, we're supposed to administer, knowing that the chances of him stepping in front of a train or jumping off a bridge is.
It's still high.
Yeah.
Yeah, and the last time I talked to psych, it's really hard to determine the risk factors for suicide as well. Like, we kind of have a sense, but then we don't, it's unpredictable. So in this case, very unpredictable what he'll do, right? And some of our patients do commit suicide, especially when they have this. So am I hearing that if we didn't go through MAID, is he at risk anyway? Yeah, probably. Probably.
I think the question was, does that count as natural death being reasonably foreseeable? And I think the
Oh, I
answer is
see.
no,
Yeah.
because I don't believe suicide is classified under natural death.
No.
Even though we have a baseline rate every year that we accept,
I think currently the answer is no.
And just for practical reasons, so most life insurance will not cover suicide. And does this fit into that clause? So no, it's actually exempt. So if one of your patients is worried about not getting insurance, as long as they follow policy, like they can't take things into their own hand because then it's deemed suicide. But if they follow AHS policy, getting assessors and so on, that is not, that won't fit under that clause.
I have a question.
Sure.
So you talked about how like HIV is treatable, but for example, if he refused to take all of his medications and then natural death is foreseeable if they refuse all treatment, does that also fit into this?
That's what fits.
Yeah.
I think that's what fits. And I think it's like your dialysis patients that want to withdraw as well, right? But not all of them have to go through MAID, right? Like you could withdraw a treatment that's offered to you without having to go through this process. So that we'll talk about options, for some patients. Yeah.
When you're dealing with dementia, if you wait till it's advanced or your death is, and unreasonably foreseeable kind of means nothing at all, you have to make the decision before you're incompetent. So where are they on that? Because trust me, I get the diagnosis, and if you don't help me, I will. Because this is a big thing in my family. I'm not going to live for 10 or 15 years in an extended care home
Yeah.
with that. So when you say advanced state of irreversible, where are they going on just, you've got the early stages, you're diagnosed but still competent?
Yeah. And
Are they forcing you to die from your dementia?
So I've really.
Because that's not acceptable.
Right. And so that's your assessors, right? And I think that's a very gray area still. And that's why I put this under a different slide, because I still think it's very gray. What is foreseeable? Is it years? Is it months? Yeah.
So, oh my gosh, it's relating back.
Are you excited about your next question?
I was going to say that I actually spoke to one of the CMPA lawyers about reasonably foreseeable, and it is intentionally, like from a legal, like with the legal terminology used, it is supposed to be vague. Like it's actually like intentionally supposed to be vague, and you're supposed to use your
Judgment.
your clinical judgment. Like
Yeah.
they've specifically done it for that reason, which makes me want to.
Yeah, it's very uncomfortable, these ones. Yeah.
So how can you use the actuarial tables to help with the natural death foreseeable thing? You've got somebody that comes in with a diagnosis, but natural death could occur within 10 years. And there's been some cases that have gone to court about this too, so the 10 years thing is sort of become a little bit more reasonable instead of 5. If they're going to die naturally within 10 years and they get this other diagnosis and they're totally intact, and it is progressing rapidly, do we use the actuarial tables about natural death to help us with the patient's request of MAID?
So in terms of the prognostication tools, you mean?
Yeah.
Yeah, and I think that's part of the assessment as well. Like if it looks beyond years, I think that's when it becomes quite questionable. What I'm seeing is months to short years as reasonably foreseeable. That's my experience so far, but I think it really depends on the assessors. And you really, I really question the ones that are many, many years, right? Because it's just.
It's probably going to get more contentious now because
Yeah.
of the big spread down in the Globe and Mail last weekend about MAID. And where they were talking about the 5 years and the 10 years
Mhm.
and
Mhm.
how people are getting around that if they
Yeah.
try.
So we had a patient call us before this started and left a voicemail, and Rocky View Palliative Care team says, I'm going to be your first patient. I'm not dying yet, but I'm going to be your first patient, and I'm well right now, just to let you know. So it's just interesting how the public is perceiving it.
Yeah.
The other one that I found a little bit you're not quite sure where things should go, but it was a patient that got made for frailty.
Wow.
He was in his 90s, sharp as a tack. I couldn't see anything coming, but kind of overall not, we use our PPS as our prognostication tool, and he was diminished. But I didn't see death at all coming in years.
Yeah, he's 92. How can you not say you're not seeing death coming in years? He's already beyond his expiration date.
Yeah. Well, we see patients that are 97
Do you think he's gonna
and
live for 10 years?
no, but it was interesting though, because it was hard to pinpoint what are we saying is the natural death. Like what are we saying is the disease, right? And it wasn't one thing, it was just dwindles. It
And
was
keep in
really-
mind,
Yeah.
we're not the assessors.
No, we're not the assessors.
So
Yeah.
the fact is, whether you agree with it or not, your job as a physician will be to facilitate what your patient is requesting or to support them. But there will be assessors who will make a call to assessors. And those assessors you may completely disagree with, and then the process gets complicated. So these things will be clarified, but they'll be clarified by the Supreme Court of Canada in a decade, because that's how long it may take.
But they're undergoing a mandatory review in 2 years from the legislation, so that's coming up this spring,
Yeah.
actually. And actually, one of the first things on the table is whether or not you can ask for it in advance, so like, with me in advanced care planning, like, whether or not this is gonna change the work in advanced care planning, because if you can request me in advance, and then also the dementia, because that's causing
Yeah.
so much angst in practice
Yeah.
for us, right?
Yeah.
Because where do you draw the line? Like, is it an album of 25? Is it
Yeah.
an album of 20? Like, where do you draw that line, right?
And all the sort of edges, these rough edges of the legislation, are all currently being challenged. The court cases are going forward. They will also be dealt with by a review process. But the whole issues of reasonably foreseeable, there will be folks that are going to challenge that because they were denied MAID, and they're now going to take that to court. And there will be folks that will be denying a number of the other provisions, not the least of which is age, mature minors, other issues such as mental illness, and all of those areas that there's a cohort of people that say, well, why not? Why did they write the legislation that way? I think that's wrong. I'm going to challenge that. I'm going to take it to court. It's going to work its way through the court system as well.
So I think, Amy, you're right. I think some things will be revisited, and I think they should be.
Yeah, because we
Yeah.
have now real life
Is that-
experience
yeah.
of like how angsty it's been.
Right,
for
right.
us.
And especially the advanced requests, I think there should be more thought put into that. So I think so we talked about some of the cases already, but I think I have to be careful when I say palliative care. Doesn't mean MAID. So if you talk to many different palliative care providers, they'll have very different thoughts about how they approach it. And I think that's their personal values and their personal thoughts. Our association has put out a statement that MAID isn't necessarily part of palliative care, but I'm not sure I personally agree with that. I think there are different thoughts about that. And some of my palliative care colleagues in Toronto, and one was in Maclean's and previous president of the college, and he is an administrator of MAID. He's a provider. So I think that it really, it just means we're different. We are different in the sense that we are sometimes walking alongside MAID. Right now, it's not what we do. And I think there was an assumption initially that all the administration was going to go through palliative care. And that's just what I wanted to clarify when I say it's not right now part of palliative care. Not necessarily that we're not involved. So does that answer some of the legislation?
A while back,
Yeah.
there was a slide about being cognitively intact when you have to give consent at the time that it's going to happen. And I've had patients that have come in and told about their family members who had very specific case, self-help campus, cancer of the pancreas, like everyone agreed was supposed to be done, or that agreed with the patient's wishes, but they stopped all the narcotics on the day of, so you've got someone who's in excruciating pain, just to be able to give something that's, that seems inhumane.
Yep.
And why is that done? Because I thought you balanced out your narcotics so the patient remains cognitively intact while they're getting pain relief.
So I think there's a disconnect right now, and I think we're trying to improve that piece. We've had forums between palliative care and MAID where the MAID coordination team, talking about how we can work better together. Because right now as it stands, the MAID coordination team works independently. So sometimes patients and attending teams perceive them to be taking over that piece entirely, including the comfort piece. So their job is just to keep the patient as intact so that the MAID team can do their thing. MAID team doesn't necessarily have to consult us at all, neither does attending team. So that's shifted a bit because we've had what you're describing exactly happen multiple times. I think it's still happening. It's still happening.
But those,
Yeah.
those 10 days between, yes, you're qualified for MAID, and like for patients in hospice, those 10 days, it's like walking on eggshells because a terminal delirium can happen, but the family has like, nope, mom or dad or whoever is going for MAID. And then I feel like a lot of moral distress because I feel like one hand's tied behind my back because I can't actually provide as effective palliative care because if they have a terminal delirium, the distraction definitely I could do to revert that to them being competent, but then, then there's a lot of existential distress from the family saying, then this person's not getting what they want, and you try to do whatever reversible, but then there's also the misconception that the opioids are going to cause delirium. So it's been very tricky.
It has been tricky.
A lot of moral distress for myself and my colleagues those 10 years.
So is it the MAID team that's canceling the narcotics then? It's the misperception that they need to be canceled.
And it's the misperception that they are taking over care. So sometimes everyone withdraws and say, well, maybe team's taking over that. Even the family has that perception.
And the family has already a misconception that opioids slow people down. So there's already this heightened concern about opioids, and so that becomes the first thing that they hang their hat on as the thing to withdraw.
No, you can actually waive that 10-day period if you think it's medically indicated, and I have done it on one occasion after having a case where I wish that I had early on.
Yes, you can definitely, so that's the other.
And worrying about them losing competence.
Yeah.
No, you can waive it whenever you want.
Yeah, so,
Who used to waive it, the doctors? or-
You, the doctor. It's all on the one doctor, it's just the provider,
Not the assessment.
not the assessor. The person that's providing, it's only on that form.
Yeah, so we'll talk about the policies as well on that, but very good point. Did you have a comment as well? Yeah, so I will definitely comment on that. But just to go back to your comment though, that has been an issue. And I got a call, and this forum came about because I got a call in distress from one of the providers saying, this patient is about to enter delirium and everyone has stepped back because the family has told them, no one touch this patient while we make sure that they can get the provision. So frantically calling people, said they thought I was going to be providing the opioids. That's not my role right here. How can you guys help? So that's where it came from. Do you remember that? Yeah, so, okay. So now we're talking about AHS policy. Can we go on? Okay. So we started to talk about it already. The request must be in writing from the patient and witnessed by 2. And from that moment, they have 10 days of reflection in theory. But that waiting period of 10 days can be shortened depending on if you're worried the patient's going to lose competency or they're dying faster than you think. So you can shorten that. And I've seen it shortened to the day of. So you need 2 independent assessors. The assessor can be a provider as well. The assessment can actually stop even before they put in writing and during that 10-day reflection period or right before the administration. And of course, at any point, they can say no to change their mind. You guys have probably seen this before, all the different stages and that's supposed to be pre-contemplative, contemplative, determination phase again. The assessment can happen anywhere in all this. And the action phase, and then which is the actual administration, and then the care after death phase, which I think still needs some help. That's another, I think, aspect of the coordination team that needs to be revisited. Right now, families are handed brochures of where they can seek bereavement and grief support, and there's no social worker on the team. And I think, in all fairness, they've just been overwhelmed with requests. They did not see this coming. Yeah.
Is it, I haven't done one for a while, is it still an automatic coroner's case when they go to
Yeah.
MAID?
Yeah.
Is anybody gonna drop that?
Yeah, I don't.
Because that's bullshit to the families.
Yeah.
They
Yeah.
wanna go forward with their funeral arrangements.
Yeah.
And then being told it's a coroner's case makes them feel like it was all illegal.
Yeah. And how many? Can you tell me how much time you've waited, like to wait for the coroner to?
We never get anything back
You
from the
don't,
coroner.
right? Okay.
They never give us anything medical back.
Okay.
So, and our bodies are being sent to Calgary,
Oh.
right? So
Yeah.
it's a huge problem because somebody has to then drive the body either way. So nobody's getting their bodies back in under a week. Okay, because they're having to go to Calgary and Calgary is always busy.
Right.
So that I am very unhappy with because the family wants to do what everybody else can do and have the funeral home pick them up that day, funeral's in 2 days.
I'm gonna bring that
They
up at our
can't
next
even
forum.
make
Yeah.
a funeral day because they don't know what
Because they don't
their
know.
body back.
Yeah.
Typically, you can ask, when the ME's office calls you, you can say,
Yeah.
call and say, we've got this case. I recently had a 21-year-old and blah, blah, blah. And then they said, but we think this is the cause of death. Can you sign it off and we'll just referee it? And everyone's had that, we'll referee it, do you sign it off sort of thing. I wonder if that's an option for people.
Because they won't let us sign a death certificate for these people. Same as we can't sign out of hospital deaths.
Right.
They're all automatic ME. And I don't think that's right. We've got a diagnosis. You've had all the medical stuff because it's unbelievable amount of paperwork you've already done.
Yeah.
Why are they going to the ME?
Wow.
And especially
You can sign on out of
No.
hospital deaths.
Actually, no, they won't let us do out of hospital.
There's a new death at home policy.
But
That prevents that?
No, that allows it.
But
Yeah.
But even,
But I don't think they.
Oh, but not
Yeah.
for MAID, but for regular deaths out of home, they can be signed by the attending.
Yes.
Yeah.
There's a new policy that just came
we
out.
can sign that out of hospital.
So,
Thanks for bringing that up, though.
Yeah, those
I
are-
was not aware of that at all. Yeah.
do you want to do the video?
Is there one more question? Is there a question?
Yeah, just might take a second.
Yeah. So. Yeah, so I'm just going to show you a video, not from our AHS, but actually some from University Health Network in Toronto, but they have a very similar service. And I thought by seeing it on kind of an interview basis that you can get a gist of how our AHS policy works.
Like the way that video, it sounded like I wouldn't feel very comfortable suggesting it to those patients. It's such a personal choice.
So we'll go back to those cases when people say, I want to end it. How do we approach that? Do we bring up MAID as one of those choices? So I am clarifying now, what do you mean?
Yeah, I can understand
Yeah.
that situation.
Yeah.
I couldn't imagine actually bringing it up unless they've made some indication that.
Right.
Talk about ending it.
Yeah, yeah. I think it's in the context of when people say, I'm done. What do you mean by done?
That we're not ignoring that.
That's right, that's right. And I think it's like suicide. People used to think if I talk about suicide, they'll commit suicide because you've put it in a pebble in their head. But same with MAID. I don't feel that's the case. We talk about it quite openly. Is this what you mean? You want to stop things, or are you asking me about assisted death?
Okay.
So, yeah.
Are you aware there's a Christian doctor's group challenging the colleges, saying you must ethically refer if you will be involved? Because personally, I have that problem with my colleagues. There's a few of them that are in that group. If a patient mentions that to them, they will drop them as a patient immediately, and they will not tell them where to go to actually have help. So I have a huge ethical concern
Yeah.
with, and again, we're talking about small communities where people literally don't know where to go.
Yeah. And let's go back to, sorry. The determination stage. I want to answer your question.
We're going to come back to this when we talk about residents, what we have to tell them, and what we have to know, right? Where do we have an obligation? When they're at the pre-contemplative stage and they want to talk, you're obligated to have that conversation with them. And you're obligated to give them information about assisted dying. So that group is the Tony Latner Center, so coming from the Jewish hospital, and they do the community health. And what they did, I thought was brilliant, which our group, I think, is still catching up. So what they did is, even before the legislation, they sat down as a group and said, we are the only physicians providing this community health and community palliative care in Toronto. They really were transparent. Let's talk openly about what we're willing and not willing to do. So we're going to talk about values again later on. But what are your values? What is your religious background that may prevent you of not being a conscientious objector? And you don't even have to label. Like, where are you in this stage? What will you be a provider? Will you not even want to be at the pre-contemplative stage? So they went around the table and were very, very transparent. And some of the providers were very religious or had a faith-based affiliation and said, I don't want to refer. And so they had just a code to say, so you're sort of just shifting some of the responsibility to say, I have a patient that's requesting MAID. That's what you're telling your colleague. You're not referring, technically, you're just telling them. But that's a clue to say, hey, I'm going to take over.
We had that conversation as a practice.
Yeah.
We actually, because I did a MAID presentation and we did a sort of a survey.
Yeah.
Of 16, 3 of us are willing to be part of the process. About another 6 are willing to at least give them the information and refer them. The others have said they will not discuss it, they will not refer, even to say, go see so-and-so. So within our practice, they within our own practice, they've just said, I refuse to have anything to do with it, and they won't even tell them to see one of us. So we have a group that'll be like, yeah, we don't want to be part of it, but we're aware we can send them to you. And then these few that, so we've done this survey. I don't know what to do with these people.
What about the receptionists?
It is, yeah, my staff should send the AHS
Yeah, but-
website and that there's the
But
follow and.
our receptionists don't know why the patients are there. Okay, they're not supposed to know why the patients are there.
Anyone have any thoughts about
So
that?
how do I deal with?
Because that,
General communication in the community, put some posters up, so that it's not targeted at any one individual, but the information is there about, if, we're going to hold an open session about it, or if you want to talk to someone about what the options are.
And it becomes a community knowledge base in most, Rocky's a fairly big community, but certainly in small communities, people just know
But they don't know.
when you're 15 years old and you have an unexpected pregnancy, there's no sense going to Dr. So-and-so. You go to Dr. So-and-so, because Dr. So-and-so will not refer you. And the same thing in communities, they will know. It's just new enough that they don't know yet, but they will know over time. There's no sense going and talking to Dr. So-and-so about MAID.
The other thing is that if people are Googling
which is what everybody does. And literally all they have to Google is Alberta and MAID, and they look at the website. And if they contact that MAID team anyway, the MAID team knows who the physicians are in the town. That's the first case I was ever involved with. That's how.
Which is part of the reason why the whole MAID coordinating team came together in the first place.
Very senior,
Yeah.
so, yeah, not Googling anything. I mean, we've got people in town that don't know that you shouldn't see Dr. So-and-so if you're talking about an abortion or post-abortion care, right? Trust me, information about who will or won't do things is not in the community, not even for things that have been going on for a decade.
Okay.
Are there
Yeah,
still-
really not.
Are there still local papers? I remember years ago in Sundre, if you remember Grant Hill, he was a Reform MP and MD from Okotoks, and he was in House of Commons with all kinds of anti-gay sort of stuff. And then Sundre, they wrote an op-ed in the local paper, the local doctors just laying out this sort of thing.
Yeah, I see, and I have this issue because we are one group. We can only do things if the group agree.
But if you have consensus in the, I mean,
No, because we have to have a majority decision.
you can't write it.
So we can't do that. So I am talking with our palliative care nurse, which we only have sometimes, because we don't have very good palliative services at all. So if a family is starting to go to palliative care, that maybe if something is said to her, they will know who to pass them on with. But I am kind of stuck because I can't put a poster up. I can't go to the newspaper.
What about your PCN?
PCN can't either. The physicians control the PCN, the physicians have to vote for it.
Are those physicians not actively against college guidelines?
They are. They are.
Like, that's, yeah, of course there's ways around it, and yeah, like you say, people find out, but ultimately, like, they're not behaving according to the code of conduct, you know?
Maybe you have to have a college person come in and talk to the.
Yeah, I was gonna say, those
That's what
meeting
I
names,
do.
get some advice from college.
Yeah.
Like, ultimately, it's
Trust me
wrong.
with these ones, that's not gonna help.
And patients
They're actually
can-
the ones
patients
that are taking
can-
that to court.
I mean, patients can make a formal complaint to the college if they believe they've been inappropriately treated by any person. Anyone can make a complaint to the college, and the college can act on any complaint that comes from any place.
Yeah,
But I wonder, there are things that we have duties to report colleagues, and there's things in the standards.
Amy?
Just wondering, does your community have like an AHS primary care facility for public health? For
You have home care and public health.
yeah, we have a hospital.
immunizations, so maybe just kind of circumvent your group practice.
That's what I'm saying, because community
advertising.
health has nothing to do with these people. It's whether anybody gets referral of our palliative care nurse. Public health only deals with vaccinating babies,
No,
trust
but
me,
you
main
put
part.
on, they could put AHS posters up or have leaflets about if, you know.
Only if
like-
AHS tells them to.
So maybe in the interest of time, this is a great discussion, and I think there's lots to talk about, but we're short on time, so we're going to move on. And I think we're going to bypass this because we
It is
sort of
very
talked about this already, which may not happen, as I'm hearing, in the rural areas, have that kind of specialization team and a more kind of coordinated process. But we were just talking about professional obligations. They're saying the same thing across the board. You have to refer. So, you actually have to give the information and refer if you're not comfortable. That's what we have. Those are our obligations. But that doesn't change how we feel about it. And I think this is what you're really having to teach your learners. How do you feel about it? Where do you sit? What are your morals and values? Is it about my moral values or is it about the patient's? Can you put them aside? Can you do this? Which stage are you comfortable? Are you willing, I talked about this already, are you willing to be a provider? Are you willing to help with the aftercare? Where are you? And I would say even within our group, it's very divided. I've been throughout the process and some of my colleagues will not see the patient as well and ask someone else to see instead. So I think having your learners really think about how they feel about it, take the time to do that because it will create a lot of angst if you say, please see this patient, this is what you're obligated to do. So it's just not the policy and the process, right? It's about reflection. Okay, next slide. Maybe I'll take a vote here. this is quite long, and it's about a psychosocial supportive care psychiatrist that works for palliative care, responding to patient asking for MAID, kind of in real time. It's more about communication. Should I show it, or do you guys feel comfortable? It's about 10 minutes long. We can cut it short. Maybe start it, and we can pick some gems from it. Okay.
Trying to develop this.
So, if only life were so simple. I mean, university professor, philosophy professor for decades, cognitively intact, has considered all the options and has been presented with all the options, including understanding the palliative options, has thought this through, has clearly articulated, brilliant woman, obviously unwell, obviously near the end of life. You know, these are the cases that, yeah, you can kind of say, okay, not a lot of moral distress over this. But we do see the patients, as Jacqueline's talked about, who, and that has been mentioned, who reduce or limit their medication for fear of losing capacity. And I think we don't see, as a palliative care team, the patients who don't want to see us for fear that we are simply going to complicate their decision. And there are many patients who I know, they don't want us to walk through the doors because they are fearful that someone's going to try to talk to them about options. And yet, what part of medicine do we not talk to patients about options? When you obtain informed consent from patients, usually there is a process of making sure the patient understands the options of treatment versus not treatment, the options of plan A versus plan B. And so while I would encourage patients to have the option of a palliative care discussion, not necessarily a palliative care consult, but a palliative care discussion about what the options are, I would also not insist upon it. And so we're in that kind of gray area. As a palliative care consultant, I don't like seeing patients who have no interest in seeing me, who would rather I turn and walk out those doors. It's very hard to do a consult on someone who does not want to talk to you. But I think we do have a duty at some level to provide information about the what-ifs. I spend a lot of time talking to patients about the what-ifs, because I think people live in fear, and fear is a powerful motivator. And knowing what the options are, I think, helps people. And so I do talk to people about, you get the patients who are terrified that their death is going to be going to be a respiratory death, or that they will die in a confused state or a delirious state. And we talk to them about, well, what would we do under those circumstances? And I think with any of these things, we need to be prepared for the fact that any number of things can intervene, and we need to be able to respond to them, whether it's in the pre-contemplative phase, whether it's in the contemplative phase, whether it's in the 10-day waiting period. And I think patients need to know what the options are, or at least they should be provided with the ability to have that discussion.
So should we skip over this?
I think most people, in some regards, understand the concept of palliative sedation. We do it as palliative care consultants. Most family physicians working in smaller communities are aware of palliative sedation as an option for situations where there are intractable symptoms that cannot be managed any other way. We most commonly use palliative sedation probably for intractable delirium, restlessness, agitation, and respiratory distress. I'm actually a little surprised at the statistic there that pain was 21%. I find that we're most frequently using it for delirium or respiratory distress. But palliative sedation is a tool that we use quite consistently. We've been doing it for decades. We use it in an appropriate way. But we are finding that palliative sedation, if it was blurry before, it's even blurrier now, because we get those patients who have become cognitively impaired. Their families tell us they would have requested MAID. Their families request MAID on their behalf. They say, we would like, mom would want MAID now, but mom no longer has capacity, so mom no longer falls under the guidelines. And so we have someone who's perhaps restless, confused, agitated. We try neuroleptics don't work. We consider palliative sedation. The family requests MAID. We offer palliative sedation. They push the guidelines wanting the palliative sedation to be a certain way, meaning can't you just give a more lethal dose of the drugs you're using for sedation? So we then find ourselves in this sort of unsettling situation of sort of not always knowing for sure where the boundaries are and being pressured. So we are in that gray zone. And from my standpoint, palliative sedation, I still try, sometimes unsuccessfully, to stay in the sort of palliative sedation mindset, which is my intent is to relieve suffering. My procedure is to administer a sedating drug. And yet often, many people around me, the family, sometimes nursing staff, sometimes a variety of people, are really thinking we should be here and wondering, one of the most uncomfortable things is when the family is pushing for MAID, we have started palliative sedation, and we're 3 days in, we're 4 days in, we're 5 days in. The patient now is anuric. The patient 6 days in is having long apneic spells. And the patient dies on day 6.5. And that's a very long 6 days when you've got a family that wanted MAID and the patient was not eligible for MAID. It's a challenging thing. But on the other side, I recently had a case of a patient in hospice. It's a hospice that does not provide MAID, and therefore the patient would have had to be transferred. And the patient requested MAID and had capacity. And everything, the wheels were all starting to move. So the MAID team was going to come, the assessments were going to get done, the transfer was being arranged, and the patient was rapidly losing capacity. And everyone was in a bit of a state of panic. The nurses were kind of panicky, like, I don't know whether we're going to get this patient transferred fast enough. And part of me said, and in fact, I did say this out loud, we need to be cautious that we don't get too anxious about the fact that we may offer this patient a peaceful death, which at one point was a good thing. But everybody was so worried that we weren't going to get MAID done in time. And yet I knew full well that we could guarantee that patient a peaceful death, because I knew that patient was headed potentially for palliative sedation. He's probably going to die in 12 to 24 hours, sedated, calm, peaceful, unresponsive, hopefully family at the bedside. And that used to be okay. Everybody was so panicked about whether we can get this patient transferred. I said, maybe the worst, maybe we're going to fail this patient by giving them a peaceful death. And it's a challenging thing where we find ourselves in this horrendous state of anxiety, trying to get a whole bunch of bureaucratic stuff done so we can give a larger dose of medication to speed the process, when in actuality, the patient will probably be fine from a sedation, calm, peaceful death section.
So maybe we'll just briefly talk about those cases. So remember this young guy imminently dying, in and out of consciousness, so not eligible for MAID, right? This is a patient who should be thinking about a palliative sedation if the family is saying he wouldn't want to be like this. We can sedate the patient, remove the octaflow, let them die. And this gentleman, eligible for MAID actually, and we should talk to him about that and talk about his options. When is he thinking? Is he thinking the next crisis, or is he happy? Which stage is he at? And is he worried about dyspnea? Is that one of the big drivers? Would palliative sedation be okay, or palliative care, start some opioids? Is that enough? Maybe not enough. Maybe he wants the MAID. So to address that. Okay. And this last patient, again, definitely eligible for the MAID if you want that. And they already have a date picked out we should be supporting them in that process. So just key topics for us and our learners. So we went through a lot today. Legislation, policy, process. I think that's the knowledge bit. But the skills piece is what you saw Dr. Roden do with the patient. Tell me about yourself. Individualize the patient. What is their intent? Do they know their options? Addressing suffering. Approaching empathetically. So that's the skills and attitude piece that we should be trying to model and also to teach your residents. But you might feel differently, about what you would do and what your resident do. We talked about how even amongst colleagues is so contentious. So definitely your learner might feel, well, what's the big hang up? I'm okay with, seeing this through with the patient. Or I'm not comfortable at all. I don't really want to talk to this patient. So just to acknowledge that as well. We can feel differently. That's okay. How are we going to approach it? What are your obligations? And we really had good discussion about this, some of the barriers. And I learned a lot actually just listening to what you guys go through in the rural areas when there's very few physicians and very few resources. And the MAID team's not going to drive out 5 hours, right, to see every patient that wants it. I think really this is the essence of what you should be teaching your residents to do. You just have to acknowledge the suffering and the fear of suffering and what it means when they have a terminal illness. Sorry, it's awkward, but. Any other questions? Sorry, we kind of breezed through that last bit, but I think we had lots of good conversations. Yeah?
Just one kind of, in your experience, the patients that have asked you about MAID and you've referred, have you generally agreed with the decision that the MAID team has made? Like, most of them to be in line with what you
Yeah, I would say yes.
And
And
you
again,
think that someone's probably eligible,
yes.
agreed,
And it usually comes from values, like what are they valuing at this point, the patient themselves. So, yeah.
The primary issue is about control. Do you have situations where patients request MAID and realize that they are going to be accepted for MAID? Then that gives them a backstop, a feeling of comfort, and then they don't go through and they explore other options.
Yeah, that's.
Knowing that they've got that in their.
Yeah.
They change the date.
Yeah, I
Pretty much.
You keep changing the dates.
That's right. So this is my patient that I saw yesterday. She talked to me about MAID. She wanted all the information. We talked about it. And then she says, okay, tell me, I need to know that I can die when I want. Tell me about the other stuff now.
Yeah.
So then we talked about hospice, palliative home care. So she just needed that in her back pocket. I don't think she's going to go through with it, but she needed that.
And it actually, I find patients, at least in hospice, when they've gone through the process and they are approved and they know, 3 months down the road when their PPS is 30% or whatever is acceptable to them, it's like this big weight has been lifted.
Yeah.
And they can get on with whatever it is else that they want to do.
Yeah. Sometimes
It's
just
fascinating.
knowing that they meet criteria gives them a lot of relief.
Yeah, whether or not you use it or not.
They're not going to use it or not. But Maureen Chops and I had a really good conversation yesterday about what residents need. We actually don't know. There's no literature out there. But residents are coming to us asking for teaching. So from a curriculum standpoint at UC, no one has a set curriculum yet. It's very new for us. We don't have a lot of expert teachers. I'm not an expert teacher. People are asking for a curriculum, a format. So we are developing that, and I think hopefully we're going to come up with some things. I'm actually doing a research project with an internal medicine resident looking at the resident needs for teaching around medical assisted dying. So that's coming from them as well, right? Not just us.
So we should finish because our time is up, but you're now welcome to come and go and talk amongst yourselves, but as well, you're welcome to ask further questions or come and chat with Jacqueline and I, and we're happy to take the conversation offline. So thank you for attending and for your interest in this.